Hello again. We're going to discuss breast ultrasound findings, when to worry, when to not. And again, I'm Samatia Destunes from the Elizabeth Wendy Breast Care in Rochester, New York. So suspicious findings in ultrasound. Frequently we're looking at masses and findings on ultrasound, and we have to try to assess, what are these lesion features that we need to worry about? So we look at the shape, the margin, orientation of a mass that we're looking at, the echogenicity, the pattern, the posterior features. Is there enhancement? Is there shadowing? So the suspicion about looking at a lesion may not be solely based on any one of these, but a combination of these features that will be set off some alarms for us to view this further. So when we look at shape, we have oval, round, or irregular. So of course, some round lesions can be quite suspicious. And of course, when we think of carcinoma or real concerning lesion, we have irregular shape in mind. The orientation can be parallel to the long axis, to the skin line, so wider than tall. And frequently that may be associated with benign findings, but not always, or not parallel. As you can see in this hypoechoic area with the echogenic line, the long axis is not parallel to the skin line. This is taller than wide. And that may be something that could be very suspicious, but not in all cases. Sometimes fat necrosis can look like this. Margin, circumscribed. So typically this may be, oval or round in shape, but we look at the margins of mass. We also may have not circumscribed margins, and these may be indistinct. They may be angular, microlobulated, spiculated. When we think of spiculated, obviously that is frequently a sign of malignancy, but having non-circumscribed margins, such as indistinct or angular, we have to think that this is also has a higher suspicion for malignancy, but not always. The echo pattern, echogenicity of most masses, whether they're benign or malignant, will be hypoechoic compared to the fatty tissue that's in the area, the memory fat. Many completely echogenic masses will be benign, but that is not alone a reliable way to make that decision. So echogenicity is not very specific, so you do have to look at the other features. So the echo pattern, of course, if you have something anechoic, you're thinking of a cyst that we see on the upper right, but you may have something that's complex, cystic and solid. You may have a hypoechoic lesion or something that's predominantly isoechoic. Definitely, if you have something that's very heterogeneous, that may raise, your suspicion that maybe something is going on that is malignant. But we have different echo patterns with lesions. Posterior features. Some lesions don't have any posterior features, but there may be enhancement. So that can be associated with cysts. But high-grade cancers, those triple negatives, may also show enhancement. Shadowing. Fibrosis can cause shadowing, and you may have cancer there, or just you may have scar tissue, and that can cause shadowing, or you may have some kind of combination of both enhancement and shadowing. The associated features are the effects of the mass on its surroundings, and that can really play a role in how we think of something that's suspect or not. So architectural distortion, really, that is something that is compression of the tissue around a mass. You may have the tissue planes may be gone and obliterated by something that's infiltrating the area. The Cooper's ligaments may be very thick or strained, and the ductal pattern may look very different. You might also have an echogenic rind or echogenic rim. Edema, you may see that skin thickening. Something may be very vascular. And in some cases, for the radiologists that use elastography and elasticity, the elasticity assessment also is considered an associated feature. So the BI-RADS ultrasound assessment, if it's a BI-RADS 2, it's benign. They go back to screening. If it's a BI-RADS 3, probably benign. You may want to do a short-term interval follow-up and do some kind of continued surveillance. BI-RADS 4, suspicious. In these cases, you're doing a biopsy. And BI-RADS 5, highly suggestive of malignancy, you're recommending a biopsy. But whether you give this a 2 or a 1, it's benign, normal or benign, cysts, intramammary lymph nodes, post-surgical changes like a post-surgical fluid collection, breast implants, complicated cysts, stable fibroadenomas, those may all go into your BI-RADS 2 benign category. Dr. Berg wrote an article in the Journal of Breast Imaging a few years ago looking at BI-RADS 3 on screening ultrasound. What is it and what is the appropriate management? Many findings historically that we've assessed as BI-RADS 3, she tells us, on screening ultrasound can now be frequently given a BI-RADS 2, such as complicated cysts with debris, cluster microcysts, and multiple bilateral circumscribed masses. If you have a circumscribed oval, hypoechoic, or even isoechoic mass or masses, and there may be some minimal posterior enhancement or no posterior features, that may be typical of a fibroadenoma, you can assess that as a BI-RADS 3 on screening ultrasound and even safely say, well, you reassess it at annual screening in a year. The malignancy rate across series that they looked at 6 months is comparable to BI-RADS 1 or 2 assessment at 0.2% and at 2 years, 0.39%. So safely, you can bring these patients back to their annual screening. If you have a BI-RADS 3 lesion, and then the mass that you're looking at gets smaller or goes away, then obviously you're going to give it goes away, you're giving it a BI-RADS 1. If it gets smaller, you'll give it a BI-RADS 2. However, if you have something that increases in diameter more than 20% in 6 months, or you have any other changes like the margin looks different, the echo pattern changes, there are other associated features that are suspect, that should prompt a BI-RADS 4 category and recommend a biopsy. In their study, they found that 44% of the cancers by 12 months, they really revealed themselves. Also, if you're using elastography, stiffness may be something you look at, although, malignancies usually will show additional suspicious findings more than just stiffness on elastography. If you have multiple bilateral circumscribed masses, just like the mammogram, you may 3 overall with at least one in the one breast and then 2 in the other, let's say these findings that you see on ultrasound may be assessed as benign. What's a probably benign finding? Well, let's say this case of circumscribed oval solid mass parallel to the skin, hypoechoic to fat, may have minimal posterior enhancement or no posterior enhancement. Those are probably BI-RADS 3 category range. The data that we've had in the literature is only for women younger than 40. Those comprise most of the cases that have been studied for these benign solid masses that we find. What's another benign? Well, isolated complicated cyst that has like kind of low-level echoes. The likelihood of malignancy is very low here at 0.3%. Just like the multiple, mostly circumscribed bilateral masses on the mammogram, multiple bilateral complicated cysts seen on ultrasound may be assessed as benign BI-RADS 2 and sent them back to routine follow-up. If you have something microlobulated, oval masses, maybe microcysts, you may want to give that a BI-RADS 2 if they're simple cysts, but you may want to do surveillance if these are deep or small and there's some diagnostic uncertainty that you definitely think these are cystic. So there is a small number of cases that have been studied that limits the precision, but the likelihood of malignancy is felt to be, less than 2% or equal to 2%. So probably benign is reasonable for these. Another BI-RADS probably benign categories, if you have a hyperechoic mass and then central hypoechoic or anechoic components, maybe surrounding edema, this is suggestive of fat necrosis, not diagnostic, and again, limited data. So if you're going to call this a BI-RADS 3, this is an expert kind of opinion decision, and you want to make sure you determine if there's a history of prior surgery or trauma, correlate these ultrasound findings to what you see on the mammogram. If you see something that you think looks like fat necrosis on ultrasound, It should also be visible on the mammogram, perhaps an oil cyst, something, anechoic with a calcified rim, something very characteristic, and then you can give that a BI-RADS 2 category. If you have posterior shadowing, you really want to do real-time scanning, and there you will exclude the presence of an associated mass, or you'll dismiss the shadowing as artifactual if it changes appearance when you turn your probe. If you increase or decrease the pressure on the skin, or if you just change the angle inclination, if it gets altered, then you may be able to dismiss it. There's really not a lot of published data on this. And so if you're going to give this a BI-RADS 3, this is another expert opinion decision. Architectural distortion, that's another probably benign finding due to post-surgical change. Here, clinical history is very important because we have limited data on likelihood of this being malignant for ultrasound findings if we think it's post-surgical scarring. So expert opinion, again, to call this a BI-RADS 3 and correlate with the mammogram. If you have multiple bilateral masses, a nice article by Wolfson some years ago, actually a year ago, AJR 2022, looked at bilateral circumscribed masses on screening breast ultrasound, and also outcomes of new or enlarging masses, a follow-up. So they had these women with multiple bilateral circumscribed masses. Out of 284 women, 134 were stable over the study period. 150 women developed 465 masses, new or enlarging or changed. Out of those, 408 were oval, circumscribed, parallel, but there were new or enlarged. 68 were biopsied. There were 0 cancers. Oval, circumscribed, parallel. Most of them, 408. Biopsy 68, 340 were followed, 0 cancers. But here, they also had 57 unique masses that are new or changed. 39 were biopsied, 4 cancers, 18 followed, 0 cancers. So this is kind of nice. New or enlarging oval circumscribed parallel masses are common and mostly benign. The malignancy rate of a new or enlarging oval circumscribed parallel mass seen on breast ultrasound, if there's no associated mammographic abnormality in screening in asymptomatic women, is 0. So if you have one new or enlarging oval mass in a woman with multiple bilateral, circumscribed masses, biopsy can safely be averted, Wolfson thought, in the setting of ultrasound screening. However, if there are concurrent new irregular masses or previously an oval mass that now has developed suspicious features, well, we better carefully evaluate this for malignancy. You may need to biopsy these to prove what they are. BI-RADS 4, suspicious category. Well, findings don't necessarily have classic appearance of cancer, but sufficiently suspicious to justify a recommendation. Like this mass here, you see there's a bit of an edema or echogenic rim around it. It's hypoechoic. There's some angular margins. And this was a grade 2 invasive ductal carcinoma, triple negative in the left breast. BI-RADS 5, highly suggestive of malignancy. That carries, you give that a BI-RADS 5, high probability of malignancy, right? Greater or equal to 95%. And it could be irregular, spiculated. It could be, an indistinct mass. Where does ultrasound come in predicting biological behavior for breast cancer? Dr. Rashad looked at the role of ultrasound in predicting this, and they found that if you have a tumor with posterior enhancement, that's greater than 8 times the odds of having at least one negative receptor, and 24 times the odds of having a high-grade tumor than those without posterior enhancement. So if you have posterior enhancement in your tumor, that's a greater probability of having ER negative, PR negative status than those without enhancement. They looked at tumors with shadowing and compared them to tumors with enhancement. They had 117. Those with posterior tumor shadowing had a greater than 16 times the odds of estrogen receptor positive findings than those with posterior enhancement, and 45 times the odds of being low-grade tumors compared with those with enhancement. So basically what this is telling us is that if your tumor had posterior shadowing it's much more likely, you see the gray in this left graph, much more likely to be ER/PR positive and low grade. If your tumor had posterior enhancement, it's much more likely to be estrogen receptor, progesterone receptor negative receptors and be more aggressive. So enhancement, posterior enhancement in your cancer, much more likely to be ER/PR negative. Posterior shattering, much more likely to be ER/PR positive and better behaving. So I thought that that was very interesting. So certain features on ultrasound of the tumor show strong correlation with tumor grade and receptor status for breast cancer. And this really could be helpful for us to expand the scope of ultrasound in predicting with confidence, certain biologic tumor characteristics that are currently beyond the scope of ultrasound biorads. So enhancement, posterior tumor enhancement versus no enhancement, right? Much more likely to have those negative receptors and high-grade tumors. So that's the interesting thing about this study by Dr. Irshad. This is a 47-year-old patient, and she presents with a lump. And you can see that we have a little marker on the spot view here. Also, she has a prior clip that we can see. She has extremely dense breasts. This is a synthetic digital mammogram. And so we went ahead, and this is her area of concern on ultrasound. We did an ultrasound. This is hypoechoic. You see that this is indistinct, right? This kind of hard to see the margins of this. And it does not have any posterior shadowing that I can see. So what would you recommend next year in this area of concern? I mean, this is a mass. We have to figure out what's going on. The patient palpated this area and came in feeling it. So of course, we would recommend BI-RADS 4B, ultrasound guided biopsy to figure this out. And this was an invasive ductal carcinoma, nuclear grade 2. This is a 44-year-old presenting for a screening mammogram and screening ultrasound because she has dense breasts. And you can see that we have heterogeneously dense pattern. This is a synthetic digital mammogram. In the left breast, as we were looking on her tomosynthesis data set, we thought we could see an area of distortion. And here is a spot. This is a digital representation, the synthetic mammogram representation of the spot view over the area. And I'm going to play the tomosynthesis size for you so you can see there's a little bit of architectural distortion right there. And this is the area. We thought that this looked irregular as we went back and forth. So predominantly seen on her left medial lateral oblique view that led to the spot tomosynthesis view. And this is the area we are looking at right here. So we went on and did her ultrasound. And this is what we found in the left breast, this taller than wide hypoechoic area with shadowing. And this was in the left 11 o'clock area. So we see it best in the lung. We kind of lose it a little bit in the, when we turn the probe trans. So what would you recommend we do next? Well, we decided we're going to do, we called it a BI-RADS 4B. We had a finding on the mammogram, on the tomosynthesis, and then on ultrasound. So we did an ultrasound guided needle biopsy, and that this was an invasive lobular carcinoma, nuclear grade 2. So subtle, and subtle on the tomosynthesis, hard to see, only seen really on the medial lateral oblique view, and hard to see even on ultrasound when you turn your probe. This is a young lady. She's 21 years old. She feels a lump in her breast. She does have a very strong family history of premenopausal breast cancer. So this is her right breast, and we have multiple ultrasound images of her area of concern in the right 12 o'clock region. We have a hypoechoic mass. It does have, indistinct or irregular margins, as you can see. Maybe it's partially cystic, or you get the idea that there's some increase through enhancement too. posterior enhancement of this mass. The patient is very young. So what would we do next in this case? Young patient, strong family history, ultrasound guided biopsy, and you can see the biopsy going right into that area. And this was an intraductal papilloma peripheral type. This is another patient, comes in for screening mammogram and screening ultrasound due to dense breast tissue. And the patient has heterogeneously dense breasts, and this is her synthetic digital mammogram. So we read this as normal. And the patient went ahead and had an ultrasound. And as we're getting through the left breast, almost at 12 o'clock, there's a subtle hypoechoic area that you can see in the lung and trans. It's tiny, perhaps 4 to 5 millimeters. So you do have to do screening ultrasound thoroughly and slowly. If you go very fast, you may miss something this subtle. So of course the mammogram was okay, but this is small, it's ill-defined. So we ended up, calling this obviously suspicious and doing an ultrasound guided biopsy that was a small invasive ductal carcinoma, ER/PR positive, HER2 negative. Another patient here, you can see post-surgical changes or surgical clips in the left breast, and the patient's had a prior left lumpectomy. The patient has dense breast tissue. As you can see on the synthetic mammogram, we've read this as normal, but however, the patient requested ultrasound because of her personal history and dense breast. So in the right breast, remember the left breast had the lumpectomy. The right breast looked fine. In the upper outer quadrant, you see this hypoechoic, kind of taller than wide area that is very ill-defined. And we can see it both in lung and trans. So this is in the upper outer quadrant of the right breast. It was hypoechoic, it was distorted, it was alarming. So we did a biopsy of this under ultrasound, and this was an invasive ductal carcinoma, nuclear grade 2. This patient's 57, and she felt a lump. You can see that we have a marker on her breast on the medial lateral oblique view, and also here it is on the right cranial cauda view. Personal history of melanoma in this patient at 44. She's now 57. And also she had a recurrence of her melanoma at 46. We could not see anything on this mammogram to cause this patient concern. But of course, we're going to ultrasound the patient and find out where area of concern is. This is her ultrasound. This palpable area was very far lateral. So had to turn the patient on her side and really feel for what she was feeling, kind of on the edge on her chest wall laterally. You can see that this is this hypoechoic large mass in her area of concern. So we ended up obviously doing a needle biopsy. Here's our needle coming in and going through the lesion. And post biopsy, put a little marker in it. And then when we really knew where that area is, because the technologist kind of put the marker where she thought the patient was telling her, but sometimes you obviously have to check and triple check. So now we can see how far lateral this was. And here's the mass on this view, this post biopsy clip mammogram, and here you can see the edge of the clip. So there's a mass that we see only partially, and this turned out to be metastatic malignant melanoma. Very sad for this patient. So all things we find are not always breast cancer. We sometimes find recurrences from other primaries. This patient came in for a diagnostic evaluation. She had felt a lump in her left breast. She has a left lumpectomy and radiation. You can see that the left breast is post-surgical. There's architectural distortion, coarse calcification, skin thickening from radiation. The left breast definitely looks very different than the right breast in this patient. And when we reviewed the mammogram, we thought this was all post-surgical change. We did not see anything, that would look alarming for the patient. However, we had to do a view where the patient's lump was, and her lump was kind of high up. And here's a kind of a tangential view of what she was feeling, very attached to the skin almost, as you can see. That's where the marker is, right? And the lesion that she's feeling is right under the skin. So we did review this very carefully, and that's the area of concern, a very superficial mass. So we did an ultrasound. You see some skin thickening up here, and then we have this kind of, partially cystic perhaps area, very attached to the dermis or close to the dermis with some flow. And so we didn't know what this was, obviously, and we were kind of concerned about it. It was 10 centimeters from the nipple, so really chest wall, not breast at this point. So we went ahead and did an ultrasound guided biopsy, and this was an atypical spindle cell proliferation. And the pathologists, they favor some type of malignant process. So of course, this was excised, and this was a malignant spindle cell neoplasm and post-radiation sarcoma, nuclear grade 2. This is another patient that comes in for a screening mammogram and ultrasound because she has dense breast tissue. And so this synthetic mammogram from her digital breast tomosynthesis was interpreted along with the tomosynthesis. This was normal. And this is what her screening ultrasound looks like. A good size mass, a hypoechoic mass in the left breast at 1230. And here is the lung and the trans of it. And of course, this has to be sampled in this patient. We didn't see this at all. The patient had not palpated anything in that area. So we biopsied this, and this was a spindle cell lesion. Differential included phylloides or a cellular fibroadenoma. So this was excised, and this was a benign phylloides tumor. And these are my references as we came to the end of this talk. And I want to thank you for your time. And this is my email address if you have questions after this.